Thank you very much for joining us today. I'd like first to introduce you to Bond before we start this conversation. So, Bond is the UK network for organizations working in international development and humanitarian response. We connect members, convene learning spaces, and support stronger policy and practices. We bring organizations together to share evidence and share better approaches. And today's discussion sits firmly in that role. My name is Mustafa Sufi, and I am Bond's humanitarian advisor. So, health systems strengthen links emergency response with recovery and long-term development. It improves outcomes only when systems function in fragile and conflict-affected settings. Is very difficult in such situation. Governance is weak. Funding is short-term, and humanitarian development actors often work separately. This work also reflects the triple nexus. You see humanitarian response, development, and planning to peace building, which come in all of them together through health systems strengthening. It shows how integrated approaches can create stability, improve access to support, long-term system resilience in fragile settings. Bond members work in this kind of settings and environment every day. Many of us want practical ways to shift from service delivery to system impact. You want approaches that survive and deliver security, political change, and fragmented coordination. And this session helps address those needs. Today, we've got four distinguished speakers who will actually highlight their experience and also to give you critical and empirical evidence about the work. First, we have Dr. Maria Burton, who's a health system researcher with more than 15 years experience working in fragile and conflict-affected settings. She's a reader at Queen's Margaret University, Edinburgh, where she is involved in a number of research projects, including Rebuild for Resilience. And we're very glad to coordinate with them today for this kind of important discussion. This program is funded by FCDO, and also she is a UNHCR funded project on refugee integration in national health systems. Maria is currently chair of the thematic working group on health system in fragile conflict-affected settings of Health System Global. Second, we have Dr. Fatima Ibrahim Loan, or Luan, is a medical doctor and a seasoned public health professional with more than 8 years of experience leading nutrition, health system, and strengthening programs in Northeast Nigeria. She has served in senior leadership roles with the International Rescue Committee, including team lead for the USAID or FCDO, HRON, which is Health Resilience of Northeast Nigeria program, where she oversaw a health system strengthening consortium advancing reproductive, maternal, newborn, child care, and adolescent health. And also, she's providing technical expertise in immunization, delivery in fragile settings. She's widely recognized for her strategic leadership, program quality oversight, and commitment to improving access to equitable and sustainable health services. And third speaker, we have Naomi, is the global practice lead for system strengthening at the International Rescue Committee. She brings more than 15 years of experience in governance, health system strengthening, and service delivery in fragile and conflict-affected settings, working with donors, government, and implementing agencies. In her role, she leads IRC's global strategy in system strengthening, develops technical standards and tools, and support country programs worldwide. She also advises on policy advocacy, research, and global partnership, and represents IRC International System Strengthening Fora. She's also involved in the Rebuild for Resilience research project funded by FCDO. Last but not least, we have Jian Lee is a global health practitioner with over 15 years of experience, specializing in community-based and primary healthcare systems strengthening across the globe. She's a program manager for Commissioned Research and Policy Advocacy Advisor, which is UK focus at the George Institute for Global Health. Previously, as a senior health advisor at World Vision UK, she provided technical leadership for health projects in fragile and conflict-affected settings. Since 2022, GN has led a consortium of 9 UK-based international organizations draft a policy brief on health system strengthening fragile and conflict-affected settings, which is provided by FCDI interest and resulted in a co-hosting policy roundtable. She identified needs that lead to follow-up research conducted with the Rebuild Consortium and International Rescue Committee on operationalizing these principles, which will be presented during the webinar. Without any further ado, I'd like to hand it over to Dr. Maria to give more information, also to deep dive into this webinar. Thank you very much.
Thank you, Mustafa, for the introduction, and thanks Bond and Action for Global Health for hosting us today to present the finding of the study and discuss them with you. Just to give you a little bit of background, this is work that has been done by the Rebuild Consortium, and really with the aim of kind of starting the conversation between all the actors. The point today is to kick off a discussion and a debate, very open, to try and bring down silos between researchers, funders, and different types of organizations doing health system strengthening in fragile setting. Where and how we started this research? Well, we all know that health system strengthening is essential for a sustainable improvement of health outcomes in fragile setting and across the world. And we know health system strengthening is at the heart of a nexus. It connects emergency response with recovery and long-term development. However, how to do health system strengthening in practice is something that we all struggle with, both in kind of in the research side, but also obviously from the implementation side. And this is even more complex in fragile and conflict-affected settings, where there are different priorities and tensions. So that's what was our starting point, and this is what we really tried to kind of unpack today and in our study. So next slide. Action for Global Health has worked a few years ago on a brief that you have a link there, and many of you are aware of and have been involved in developing on what works for health system strengthening in fragile setting. But really, our discussion took a little bit of a step back. We kind of know more or less what works, but how it works, what are the challenges, and how can we make it happen, because we know that the difficulty is in the actual doing it rather than thinking about what to do. And so in this study, we really wanted to capture the operational perspectives. We don't want to have an academic discussion today, but really have a very operational, experiential perspective about what are the experiences of doing health system strengthening from a range of actors involved in that at country level or regional and global levels. And because this is not an academic discussion, I don't want to go in long and complex discussions about the definition of health system strengthening. But I think an important point to make is that here we want to be very clear about the distinction between health system strengthening that is really related to the scope, the scale, the sustainability, and the effects of the intervention, and health system support. And we can come back to this in the discussion, but it's important to keep in mind that we're really focusing on health system strengthening and not in kind of focused or short-term and ad hoc health system support. Next slide. So what we did for our study, just very briefly before I dive into the finding, it was a kind of a mixed method approach, mostly qualitative, with interviews at different level. We had expert interviews at global and regional level with 25 experts, and you can see the breakdown on the side. But we also had an elicitation, a photo elicitation kind of exercise with a country level practitioner working on HSS in 11 countries representing 8 NGOs. And this is a kind of a little bit of a different approach to research, where we're not really only sitting down and having the interviews, but iteratively we discuss the topic, and then we share, the practitioners share with us pictures that represent health system strengthening to them. And then we had the sense-making interviews to kind of unpack what it means and what it represents and why and so on. So that was quite rich, and you will see some of the pictures in the slides. And then we did a document review of 63 documents, mostly emerging or suggested during the interviews. Obviously, our approach has some limitations. In particular, the approach in terms of selection of participant was purposeful and limited in the sample that we got. It's mostly focused on international NGOs that work in humanitarian sector and focused on service delivery. So we are missing, and we are aware of that. And obviously, this is the space to discuss this and to complete the study. The Ministry of Health and the national counterparts, as well as development-oriented local and international organizations. Next slide. And the next. So in terms of findings, I would cover 4 main themes that emerged from our analysis. And you can see them on the screen. And for each, we want to highlight the challenges. Many of those were not going to be particularly new to you. You know them. You've been working in these settings for a long time. You know what the challenges are. But also what emerged in terms of entry points and promising approaches. But also in terms of what are the open questions, what are the blind spots that need to be more kind of unpacked and reflected on further as we move forward. Next slide. So the first theme is really about fragility, insecurity, and human priorities. The question that emerged many, many times during the interviews is, how can we do health system strengthening in a place that is insecure, that is uncertain, and where the basic hardware of the health system is missing? So this is an obvious challenge, but what came about, next slide, is that there's 2 main narratives that came up. One narrative is, in these settings, we really have to focus our priority on saving lives. And maybe health system support at most can be done, but really nothing more than that. And this is perhaps a minority, a very small minority of respondents who mentioned that. Because the agreement among respondents, and I think increasingly in the humanitarian community, is that there is a potential to lever the humanitarian phase for health system strengthening. And many examples were provided of crises that have opened a window of opportunity for HSS, in, for example, COVID-19, the case of Ukraine, also the case of Ebola. And the argument came out quite clearly that during conflicts and crises, vulnerabilities are more visible, and therefore it is perhaps more easier, in a sense, to target those vulnerabilities that are emerging with health system strengthening approaches. So the first question was really about, do we need to do that? And I think there is an overwhelming consensus that yes, even in humanitarian phase, it is important to keep in mind consideration about health system strengthening. And again, we can come back to this in the discussion on exactly other research examples that we have on that. Next slide. And one point that emerged, again, along this kind of discussion is the role of a nexus, what some people call that wretched nexus stuff. The nexus is the framework of reference for embedding HSS into the humanitarian response. But most, or if not all, the respondents agree that is really difficult to operationalize the nexus beyond kind of just tick boxing exercise in program writing. And some of the suggestion that we heard about what to do about that is really to start with financing, start increasing the transparency of funding, both in humanitarian and development, and what activities are carried out to make the nexus not only a paper exercise, but something that kind of can be unpacked in practice. And a question remains on how to bring the knowledge of more development-oriented agencies into the fragile setting and into this operationalizing HSS in humanitarian settings. Next slide. The next challenge that emerged constantly, and you will well imagine that, is the issue of governance. When we think about health system strengthening, we think about a government that can support that can ensure the sustainability of exercise, and that it's actually there to provide leadership and stewardship. But in places where there's lack of political peace and weak governance, this is really, really difficult. And therefore, that core element of HSS, which is sustainability, it's really impossible to put in place. And there is a clear trade-off between getting stuff done, compared to working through the government. Next slide. And some of the entry points emerged in terms of how to deal with that. One point is about many examples of working with local authorities, whether they are de facto or ethnic authorities that are perhaps not internationally recognized, but they have a legitimacy within the context. There is also increasing evidence about working with non-public actors, community actors, civil society, faith-based organization, private sector, and so on. But the point is, and we'll come back to that, that this requires more donor flexibility in doing that, which some donors allow and some donors do not allow. And it also requires politically sensitive approaches and engagement, longer-term engagement and good knowledge of the setting, which sometimes can be a challenge in a very rapid response. So next slide. Other approaches that emerged and that were particularly interesting, obviously it's the question of ensuring ownership and ensuring that transition are carefully planned to ensure ownership. And one element that came about that is particularly interesting is the question of visibility. Obviously NGOs have an incentive or a need to ensure their own visibility because of fundraising reason, but at the same time it was seen that a key approach to ensuring addressing the governance issue within the health HSS programming was to ensure the visibility of local authorities, of a government or the district level authorities in place. And we had a few examples, including from Nigeria, we will hear about it now, and from Somalia. Next slide. The third main theme that came up during those discussions is about the aid architecture and how the aid architecture that is fragmented both between the humanitarian sphere and the development one, but also within that with different global health initiatives, multilaterals, bilateral donors, and so on, create a series of very conflicting mandates, agenda, and interests that creates some sort of barriers in doing health system strengthening. The funding is fragmented, is very short term, is focused on service delivery and countable outputs. The outputs are often in terms of life saved and not in system strengthened. And this is obviously a problem for health system strengthening programming, especially in fragile setting. And what we heard is that really there should be a move to making health system strengthening programming intentional and intentionally embedded in any health programming. Without that intentionality, it is really difficult to move from health system support to health system strengthening. And as Mustafa was reminding us, focusing on primary healthcare approaches, focusing on the integration of health services is something that emerged constantly as an option, as an entry point to ensure HSS also in challenging circumstances. Next slide. And within that aid architecture problem, one element that emerged multiple times, and we know very well also in the literature, is the issue of coordination. There is a sense, and again, that should be explored perhaps a bit better, that coordination is better during the emergency phase when the health cluster are in place. And that kind of breaks down over time when the health cluster stop working because of it's not an emergency phase anymore, or when a more kind of mix of actors start working within the same context. And that remains quite an open question. There's no clear examples that we found in the discussions with the practitioners about what to do about that. There's suggestion that maybe World Bank or perhaps regional bodies such as Africa CDC could take this role of coordination also when the situation moves to a more kind of a recovery phase. But this is, again, a question open for discussion. Next slide. And then the last element that came about in the interviews with practitioners is about risk management and the support structure for NGOs. This, again, is something that you're probably very familiar with, knowing that the relation between funders and implementer is sometimes problematic. There is a sense that a lot of risk is shifted to NGOs, both programmatic risk in terms of getting stuff done, but also fiduciary risk in terms of how the money is used. And more and more risk is shifted toward NGOs, but at the same time, they don't have enough decision space, enough flexibility to adapt their approaches to the risk that they are taking in delivering. And therefore, that becomes a little bit of a bottleneck, and NGOs then kind of shift to more risk adverse approaches where they're trying to limit the risk and focus on service delivery rather than on trying to do HSS and strengthen local system. And again, we've seen that there are options to deal with that. And the example for Nigeria will specifically focus on that. Intentional, flexible approaches to HSS programming are really essential to make sure that HSS work, health system strengthening, is something that it needs longer term frameworks and needs to be flexible and adapted to the context, can't be a one size fits all. So, different approaches have emerged, but in general, the sense that with longer term funding, different approaches to measuring HSS, and a different balance of risk management, for example, allowing NGOs to use at least a percentage of a funding to try new things, to do things differently, that would allow health HSS programming to be better embedded within health programs. Next slide. So where do we go from here? What this kind of quick overview of our study, how do we take on the discussion? I think hopefully this study allows to open up a little bit of a black box of what happens, what are the experiences and the perspective of implementing actors that are a bit of a middle level in the ecosystem, and sometimes a bit overlooked when we focused on communities and government and have a dialogue with funders, but not really with implementers. And hopefully these findings allow us to come with some recommendations. And we have a brief that is coming out. You'll have a QR code to that if you're interested in downloading it. But also, I hope that this opens up a discussion between researchers, funders, and NGOs implementing agency about how do we do this in practice. Next slide. And as a researcher, the key point for me is about the knowledge research agenda and the knowledge agenda in general, also the knowledge transfer agenda that, again, we can come back to in the discussion. I'll be really keen to hear your perspective. But there is certainly a need for more understanding and capacity building around HSS, also within implementing organization. The definition of HSS is very varying when we ask different implementing partners what is HSS to them. There is quite a bit of a spectrum, and also some things that as researcher we would classify as health system support kind of get grouped up with health system strengthening. And so we need to think about that and what it means, and also reflect on different mandates and funding sources. Obviously, being funded by more humanitarian sources means that the definition of health system strengthening and the importance of health system strengthening is different. But also we need to really break those silos, as we said at the beginning, and engage and support NGOs across the humanitarian and development spectrum in understanding better what is HSS and how it can be done. So hopefully this is really a first step in this agenda, and I'm really looking forward to the discussion. I'm going to hand over to my colleague from IRC, Fatima, for the next presentation of the case study on Nigeria. And really, as I said, looking forward to the discussion with you. Thank you.
All right. Thank you so much, Maria, for this, and thanks everyone for joining this webinar. Good afternoon from Nigeria. So I will be presenting some of our experiences implementing the health system strengthening project in the northeastern part of Nigeria, together with my colleagues, Naomi, which is on the call. So we are glad to share some of our experiences implementing the health resilience of the Northeast Heron project. So the Health Resilience of the Northeast Heron project is a joint funded project by FCDO and USAID. We've implemented the project over the period of 4 years in the northeastern part of Nigeria. And it was purely a health system strengthening project. But however, when we started implementation in 2020, that was, the peak of the COVID-19 pandemic, and a lot of issues, had happened within the context of the healthcare system, and we had to, adapt to balance between health system support and health system strengthening. And we've had, a lot of challenges in terms of, ensuring alignment with the systems, moving through the health system support, the health system strengthening, because the COVID-19 pandemic was hit, on the health systems in Nigeria. And also the northeastern part of Nigeria had this long protracted crisis. The insurgency started in 2009 and a lot of health facilities were dilapidated. We had a lot of challenges in terms of human resource for health. This project was implemented by IRC as the prime implementing partner in collaboration with two sub-awardees. We have Action Against Hunger and Society for Family Health, which is a national NGO. The project was initially implemented in Borno and Yobe, and then along the course of the project implementation, we had the opportunity to expand to Adamawa State for a supplemental activity to support the Adamawa State Durable Solutions. And also we had the opportunity for a COVID-19 supplementary activity to support the government of Borno and Yobe to achieve some of the set target by the National Primary Healthcare in terms of, achieving COVID-19 immunization among the populace. So this project was implemented between the period of 2020 to 2024 across Borno, Yobe, and Adamawa State. Next slide. So our objectives of the project, the main objective is to ensure that women, girls, and other marginalized groups are protected from and treated from the main causes of morbidity and mortality. For the Borno and Yobe state project implementation, we have 3 result areas. Our result 1 focuses on mainly ensuring increased availability of quality primary healthcare and nutrition services that are accessible to children, women, and marginalized groups. And we've worked together with the government stakeholder to ensure a holistic approach across the primary healthcare system to ensure that, the primary healthcare system, it fits to provide services to the vulnerable populace in those locations. Our result 2 focuses on improved timely seeking of health services and taking informed actions to prevent new diseases. So that gives us the opportunity to work towards strengthening community engagement, community structures, community working together with other community organizations to ensure that, people with need in those communities have access, can make decision, and also access services easily from those community, and also make their informed, decision to access those services. Our result 3 focuses on improving planning, management, coordination, and to ensure that our services are budgeted and delivered through a government-led framework. So we've worked together with the government to ensure that we deliver this, and we've aligned with so many national and subnational priority to enable us, ensure that our services are coordinated, it aligns with the national systems, and also we deliver those services to the community. For the supplementary activity in Adamawa, our main result areas focuses on quality PSC services provided to IDPs and returnees, and then vulnerable host community members. And also our result 4.2, as part of the supplementary activity, focuses on demand for PSC services is supported. For the COVID-19 intervention, our result focuses on ensuring equitable access and delivery of safe and effective COVID-19 vaccination is expanded, and also morbidity and mortality from COVID-19 are reduced through prevention, detection, and response, and also ensuring a strengthened health system. Next slide. So some of the key activities and key components of this project implementation, our focus is remain with around strengthening facility structures. We've worked to ensure rehabilitating and equipping primary healthcare facility to ensure delivery of essential services. We've had this delivered through different models. We've worked with the different ministries, departments, and agencies, and also we supported some primary healthcares that are not parts of the ones that are able to access basic healthcare provision funds. So we work together with some of the state, like Adamawa State, to ensure that we align with the Impact Fund, which was funded by World Bank, to ensure that those non-basic healthcare provision fund facilities also have like a replica of some of the funding that goes into primary healthcare to ensure primary healthcare rehabilitation, and also to ensure essential medicines and equipment available to deliver services. And we've also employed strategies to ensure longer term sustainability in terms of capacity building. We've seen that, through training, pulling out healthcare workers from those supported facilities, from time to time, we tend to see that the effectiveness is not much. So we've deployed a strategy in collaboration with the national and subnational to ensure that we adopt some strategies like clinical mentorship approach, where we identify mentors across facilities and also train those mentors to ensure that the mentors provide low dose, high frequency trainings to healthcare workers, and those mentorship skills continues across these health facilities. Even after the closure of the project, the government are able to sustain the mentors because they are local indigenes, they are workers from the government facilities, so the government are able to maintain that to ensure continuous capacity building. Also on community engagement, to ensure that our community engagement approaches are sustainable, we work with the government, to support them roll out the CHIPS program. The CHIPS programming, it's one of the parts of the national guideline that exists within the national systems, and healthcare workers, have been identified from those communities, and they have been trained according to the CHIPS national guidelines. And those healthcare workers have a mandate to improve community awareness and access for healthcare services in the communities. They are trained to improve demand generation across all the RAMCA plus N areas, just to ensure that people have timely access to healthcare services and they are aware of the services that exist. We also work to strengthen feedback mechanisms across all the communities where we work, and we ensure that our services are sustainable. So we've implemented a lot of approaches. Some of our governance approaches that we've implemented include the problem-driven iterative adaptation. So this is one of the approach that enable us to ensure that the health system is accountable, and also the service providers are also able to hold the beneficiaries, the clients are able to hold service providers accountable. So the problem-driven iterative approach allows the community structures, the ward development community, the health facility managers, and the staffs to come together, identify the root causes of their problems. And we've seen significant progress in terms of utilizing this approach for health facilities to even mobilize resources on their own, to sustain healthcare services, even, in the absence of resources that comes directly from the government gateways. So, and that's also established a mechanism for accountability within the structures that exist. We know that we have a lot of funds that are being disbursed across the different gateways to support primary healthcare systems. So that ensures accountability within the systems and ensures services are qualitative and are also timely to the vulnerable populace. Next slide. Yes, so I will stop here and then I will hand it over to my colleague Naomi to take us through some of the recommendation and then the lessons from the process evaluation. Back to you, Naomi.
Thank you so much, Dr. Fatima. Hi, everyone. I'm Noemi. I will now walk you through the process evaluation and the recommendations that emerged from it that we did on this HERON project implemented in Nigeria that Dr. Fatima just presented. So the evaluation aimed at assessing the success of the different transitioning components, one of which, for example, was the transitioning of the CHIPS, so the community health workers, their incentives payment into the state's budgets. And it also aimed at identifying lessons learned to inform future partnership-based HSS program at IRC. The focus of the research was on both operational processes, so coordination, resource management, technical assistance, capacity and sustainability planning, as well as on the transition of different sustainability domains to government partners. So that included the CHIPS, as I just said, the staff incentives within the Ministry of Health, the nutrition stabilization centers, and drug procurement for primary healthcare facilities. The evaluation focused on partners' perspective, so it was mainly made up of key informant interviews in terms of data collection, as well as a document review to identify the successes and the areas for improvement. Next slide.
So let me quickly walk through the main recommendations from the evaluation, focusing on how we can design programs and partnerships in a way that really supports government ownership and sustainability. So first, looking at program design, a first big point is integration. So we need to avoid creating components that run in parallel to government systems. Here, the recommendation is to embed things. For example, the emergency transport scheme that was developed or supported in this program. It's initially a state-run program anyway, and so the idea was to embed it directly into existing operational agencies so that they become part of routine government practice rather than being a standalone intervention, which also links to alignment and co-design. So when activities are shaped early with government counterparts and that they're anchored in their plans and policies, then transitions later on become much easier. So it's really a shift from presenting a finished design to really building it together. Then there's the catalytic role that we as NGOs sometimes play. Often the government has programs that are sitting on paper that they want to implement, but they can't because they lack funding or they lack capacity. So here our role can be to provide that initial boost, whether funding or technical support, to activate what they already intended to do. But then once things are running, the recommendation really is to step back. So that's the scaffolding approach. Let government partners run, monitor, supervise, while we provide guidance as needed in the background. So it's very much about shifting implementation visibly to them. And visibility matters. So for legitimacy, governments need to be seen leading, except in certain contexts. But so we support, but they are the ones out front, which strengthens ownership and public confidence. And finally, programs need to remain adaptive and analysis-driven, doing regular stakeholder analysis, using user research, doing iterative design. All of this really helps ensure that approaches respond to evolving needs and context rather than just staying rigid. Next slide. Yes, next slide. Moving on to the partnership approach, here the big message is the need to be politically smart. So that means understanding who the real influencers are, getting their buy-in early, and leveraging existing institutional and hierarchical relationships instead of working around them. And so here, tools like stakeholder analysis, political economy analysis are really key. And we need to stay responsive, aligned with government priorities, but at the same time, still focused on clear outcomes for people. So here, when we talk about responsiveness, it's not passive, it's about continuously adjusting based on what partners actually need. And the last category of the recommendations is around how you fund transition. So it's really an area where we saw a lot of gaps in the HERON program. It was still delivered largely as a humanitarian project. It was first designed, and then partner input and financial planning came in later, much earlier than in many other programs, but it still made transition harder. So one recommendation here is to map all available funding sources early on, including underused government streams, and then help partners to access those funding streams. Another recommendation is to secure financial commitment from government from the start. So setting matching or co-financing expectations early on so that it can reinforce ownership and also avoid being in a position where we hand things over at the end and then we hope they can pick them up. And even with, I think our exit strategy on HERON was, 3 years, or at least 2, and still in that time frame, it was too short to ensure that all of the components we wanted to transition could fully be funded and taken over. And we should also prioritize self-sustaining mechanisms. So market-based approaches here are really key. For example, the DRF, the Drug Revolving Fund, which in Nigeria is a system that ensures that there's a continuous supply of essential medicines in public health facilities by reinvesting revenue from the sales of those drugs. Also, public-private partnerships and stronger regulatory frameworks are all things that can give governments more tools to sustain system strengthening beyond project cycles and donor cycles. Next slide. So when we talk about what NGOs need in order to really move beyond basic health system support, to me, three things stand out. The first is impact measurement, and most of those recommendations actually overlap with what Maria talked about. So we still tend to default to life saved, morbidity, mortality, the classic humanitarian indicators. But if we're really serious about system strengthening, we need to shift that lens. We need indicators that actually capture changes in the system itself. And that requires a bit of reframing. So seeing HSS not only as a means to an end, which ultimately that's what it is, but sometimes you need to see it as an end in itself, because strong systems will then lead to those better health outcomes later. The second point is accepting complex processes. So as we all know, systems change is really messy. It doesn't follow neat linear log frames. And so instead of forcing complexity into rigid planning tools, we may need to let go of the sort of log frame mindset and start adopting models that are built for iteration. For example, the search frame, which I'll come back to on the next slide. So the idea here is to stop pretending that systems change is predictable when actually it really isn't. And finally, NGOs need to find better ways, and donors, not just NGOs, to bring humanitarian and development actors together. So we know that both sides contribute different things. Both are essential, but they're structurally rarely, they structurally are rarely working in sync. So if we want to achieve real systems transformation, then the two communities really need to collaborate much more intentionally. And we need mechanisms that hold all of us accountable for working in alignment rather than in parallel. Next slide. So this is the search frame. It's just to illustrate an alternative to the traditional log frame. It's a tool that's designed for adaptive programming, especially in complex systems where things don't move linearly. So it starts with a deep problem analysis, then it identifies small testable entry points rather than committing to a fixed plan upfront like we do in log frames. And then each of these becomes an iteration. So you test an idea, check your assumptions, see what you learned, and then you adjust before moving forward. And the value of this is that it makes adaptation structured and intentional. So instead of forcing programs into a rigid plan, it builds learning and adjustment into the process itself. So it's just a better fit for systems change than the classic log frame. And just to highlight that I'm very aware that log frames are mainly imposed on us by donors. So I'm not suggesting, an NGO-led revolution unless you really want to, but just reminding ourselves that there are other ways out there to monitor programs. And if there are any donors in the room, also it's on them to start that revolution. And with that, I'll hand over to June.
Thank you. Thank you to all the presenters. I think it's been really informative. And I echo Maria's comment that this is just the beginning of hearing from the implementers who are on the ground facing the issues every day, and really grappling with the different issues and challenges that has been laid out by Maria's presentation. And I think it was really helpful to hear two examples and also IRC's very helpful framework on how some of those organizations are navigating these issues. And before, so I mean, the floor is yours now, but before we actually go on to hear from you on the questions that we've laid out, we would actually like to just answer some of the burning questions. So there were a few questions on the chat, and I would like to just pick up on a few. And if the speakers, now that you can feel a bit more relaxed, if you can pick up on some of the simpler questions on the chat and just answer them on the chat, we would really appreciate that. But I'll just pick up on a few that I think would resonate with many of us. So one of the first questions was posed by Carol, and probably nobody has an answer to this, as in many other questions that might come up today. So it was a question on why there is no transparency of funding and activities among Nexus actors. I think maybe I will invite Maria back to see if there were any findings from the interviews on this, because obviously this is a hot topic. And I would just also like to add how this is really linked to the coordination and the governance issues that we have. In order for us to have a transparent view of contribution of different stakeholders in a setting, there is a strong coordination necessary. But even in non-fragile settings, this is a challenge. So it can be one of the factors to it. Maria, do you have anything to add here?
Yeah, no, I think you're right that coordination is an issue that came up multiple times in the discussion, and I think it's also this kind of different incentives that different actors face. That obviously NGOs are kind of like they sometimes feel like they have to, they have a donor, a funder that they have to kind of report back to, and therefore makes everything a little bit more sometimes sensitive in terms of sharing information. And I remember in a few interviews, people really said it's up to the donors to set up those coordination mechanisms to allow us and to set incentive that allows NGOs to really be transparent about their funding and their activities. Because as long as even the donors themselves have struggled with that type of coordination and transparency, it's really hard that is reflected onto the implementation agencies. So I think that's kind of those political economy reasons there are kind of are a little bit of kind of blocking that. And I think today it's maybe, as you said, it's really difficult to have like clear-cut answer. You should do ABC. I think it is more like really trying to unpack what these incentives are, what these situations are, and starting to think like, what are the entry points? What can be done even marginally to change some of those really kind of entrenched systems to make things better in terms of HSS?
And we have been, and we are trying to do this by really hearing from you and just unpacking examples, tangible examples from the ground, so that we may all be able to really contribute to this body of evidence. The second question I want to cover is, what are the kind of measurement outcomes that is more sensitive to measuring health system strengthening? So Sarah has asked this very relevant question, which I, again, believe, Maria, your organization has been really unpacking. And I also want to loop in Noemi, because you did suggest in your presentation that there has to be a shift in measuring health system strengthening efforts within any of the health programs that the NGOs are running. So maybe some tangible suggestions might be really helpful to those on the call.
Yeah, well, I'll take it very quickly first, before handing over to Noemi. But I think as researcher, one of the key points in our research agenda is really that to try and come up with indicators that are satisfying for NGOs and for funders. And we've done a lot of work, and I can share that in the chat in terms of measuring HSS with more kind of qualitative approach, measuring processes and what we call the health system process indicators. And I'll share a link. But yeah, definitely that's still an ongoing agenda. So handing over to Noemi for a more kind of practice perspective.
Yeah, thanks. So I think, to me, the outcomes that are more sensitive to systems are the ones that capture changes in system capacity and behavior, rather than just health outputs like morbidity or mortality. So, for example, on governance and accountability, are coordination structures functioning? Are decisions data-driven? On service delivery capacity, we could ask, are facilities consistently staffed, stocked, supervised? On financing and resource flows, we could ask whether funding is predictable, whether domestic resources are increasing. On the health workforce, is the workforce trained, retained, and supported? Which goes much beyond, those one-off trainings that we often do as INGOs in humanitarian settings. Looking at supply chain performance, are stockout durations decreasing? Are replenishment cycles more reliable? looking at information systems. Is data complete, timely, actually used for decisions? And then looking at resilience, how quickly can the system detect and respond to shocks? So those are just a few examples of things we need to look more into as we try to strengthen systems in fragile settings. Thanks.
Thank you very much. Yeah, that's really helpful, and I think Maria has inputted into the chat a further resource on measuring health system strengthening, and there's also thank you Al Hadi, who's inputted a scoping review on health system strengthening resilience measures. So I'll just pose one more question and go on to the group discussions. I'm conscious that we don't have much time, but we did initially plan it so that whoever's interested in more discussion can stay a little bit over time. And we will share the recording afterwards. So please bear that in mind. One more question that I think is quite practical again, posed by Fuad Othman, thank you, is a question on how to ensure authorities' commitment and financial sustainability, especially to answer, salary payments and supply chain. I think there was mentioning of this in Noemi's presentation. So Fatima or Noemi, I think maybe I'll pose this question to Fatima and Noemi first and see if Maria, you have anything to add.
All right. Yeah, thank you so much. One of the things that has actually supported the transition of incentive, payment for health workers across healthcare systems include joint planning with the government systems. So we have the government annual operational plan, which is the annual health sector budget. So the government stakeholders they come together every year to design budget, based on their contextual realities, and also budget that aligns, with their strategic plan. So one of the things that has actually supported the achievement of that is the initial joint planning and assessment of the gaps that exist across the healthcare facilities, including the human resource for health. And one of the things also that has supported it, instead of us recruiting staffs and deploying them to the government facility, we collaboratively work with them to identify skilled, dedicated, and also certified health workers within the systems. So, and those health workers are part of the trained, certified staffs that students that have exited from the government on health system or health school of nursing, school of midwifery, that the government are unable to absorb because of their plans, to gain resources to sustain them into the government payroll. So we had this collaborative agreement to recruit them through our systems and also initiate the incentive payments based on our agreement, based on our memorandum of understanding for the first 6 months. And the government will now key in and also ensure that they sustain that into the government system. So another step that was taken is to ensure that this transition is not, like abrupt. It's like something that comes gradually. Maybe we pull 25% of the incentive payments at the beginning. The next quarter, we pull another 25%. The government keep on, complementing the effort that we are doing. And then finally, we pull at zero, and the government finally transition them into the government system. So, and then also the joint collaboration through the annual operational plan allows them to better understand the staffing need within the system, the present staff within the system, and also include their salary payments into the health sector annual budget. And also, for example, the CHIPS payment, that was easy for us to transition because we already have a structure that guides the CHIPS programming in Nigeria. We have a guideline, we have the basic healthcare provision fund gateway from the national, and we have a gateway at the subnational level. So the stipends were originally meant to be part of the guidelines, and it's easier for us to support them, roll out the initiative, train the CHIPS programming, map them out, deploy them, and also the government, fully took over the responsibility of transitioning them into the basic healthcare provision fund stipends that they expected to receive. So those are some of the things that has supported supported us in terms of identifying gaps, bringing those gaps on board, and also transitioning them into the government systems. Thank you. I don't know if Naomi has one or two things to add.
No, that was great, Dr. Fatima. Thank you.
Thank you. No, I mean, thank you so much for all the questions and comments on the chat. They are very valuable. And although we cannot answer all of them due to time, I think I'll just quickly mention Rush's question about observation about role of trust and power dynamics in the outcome of health system strengthening initiatives. I think one of the case studies that came from Somalia, from another organization, was how they made sure that they would increase the visibility of the government stakeholders when they carry out any activities in the community level, to make sure that community can now link any of the health services provided, not to the NGOs that would normally be providing it, but also to the authority. So that's one of the longer term approaches that some of the NGOs were taking. And please also note Mohammed Jimal's really valuable comment on the chat about market system development approach, as that's very relevant. And I think maybe we can take that on, Maria, as one of the things that we can include into the study. Thank you very much. We have now got 2 minutes left, so whoever has another commitment for the next hour, please feel free to drop off. But we will if anyone's interested and able to, we will continue our discussion for the next 10 minutes. And as inputted by Mirat in the chat, the questions that we really wanted to pose to you is, what can we do as INGOs? I mean, there's a lot of external challenges, dire situations, changing environments, everything that we perhaps cannot control. Of course, we are in conversation with the funders such as FCDO and others, in really teasing out how can we change the age structure and how humanitarian funding and development funding is channeled. However, I think what's more relevant for us and what we can change today is perhaps just reflecting on how internal processes and organizational structures can be changed, and what kind of incentives and supportive environments from the funders are needed. Again, that's a little bit, how do you say, external, but then this insight is quite valuable for us to actually continue on with the advocacy work, and what are some of the knowledge gaps for us. So without further ado, I mean, it is a big group. It's reduced in number a little bit, so maybe people won't feel as intimidated. If you can actually just raise your hand, speak up, that'll be best. But please do feel free to keep putting into the chat, as I see some really valuable comments coming in. Anyone has any thoughts on this question? And I think there was actually a participant online who's asked the exact question. So Husinatu has asked this very question to be to the group. So is there anybody with any thoughts? Maybe I'll follow up with a prompt, maybe. So is there any internal processes? So I mean, what are some of the ways that NGOs have been or can be intentional about going the extra mile in embedding some of the systems building approaches, governance building approaches? I think Noemi had spoken about different indicators that reflect the result or the process result of this. So Sarah, yes, thank you.
Hi everybody. Let me put this onto. There you go. So I'm a trustee at an organization called GINA, so Gaza Infant Nutrition Alliance, and we support breastfeeding in Gaza at the moment during the conflict. And our main kind of modus operandi is training staff locally. So, we have practitioners in the UK, we've done remote training. And so it's been a case of capacity building within the local systems, and then embedding kind of policies within existing health service infrastructure, and then working our way kind of like up the hierarchy chain to get the buy-in as we go in. And so at the moment, we have actually managed to get some hospitals that have allowed our staff to go into NICUs and are implementing new kind of operational policies within NICUs. Obviously, we've also had support from much bigger organizations. We're very small, so we've had support from organizations such as UNICEF, Plan, MSF. So having kind of like the big recognized international support has been really helpful. But we've offered something that wasn't otherwise existing. So that's been really good in terms of, I think the WHO already had a protocol for this kind of like early intervention, but after October 23, it kind of fell apart. And so, yeah, basically working from the ground up to implement these changes and get buy-in as we go. We're working to kind of develop a kind of accreditation system that goes with it, so that the people who have trained with us are then qualified, who then have a certificate that they can then add, that then elevates Palestinians. And we're also working on bringing our kind of like our data into their first author papers, so that we're then elevating them at an academic level as well. So building kind of like their internal capacity so that when we can then step backwards.
Wonderful. Thank you. Thank you for that really, really helpful example. And it's really notable um, to hear your approach on elevating the local actors. I think that's really valuable. Uh, Al Hadi?
Yeah. Hi, and thanks so much for organizing the webinar. I'll keep the intervention a little brief. So I'm from Sudan, right? So one of the things that we see often in health system strengthening conflict settings is that it turns to a little bit ignore the areas where there are not necessarily active conflicts at the time. So, for example, now looking at Sudan, at Al-Fashir city in Sudan, where a recent massacre has taken place, and then overlooking the need to strengthen the hospitals or the areas where migrants or refugees would actually flee the active conflict zone. So the idea of strengthening health systems is not just about the areas where active conflicts are taking place, but also to the nearest safe spot where like there would be an overflow of migrants, and then with all sorts of like mental, physical, nutrition related support that would need to take place. And I think the second element to me is also around understanding the local civil society. So, I mean, I work in the NGO sectors myself. I understand the need for accountability and like very detailed processes to track the money and everything. But also, like realistically, if you are dealing with somebody who is like from a village somewhere where there's a conflict, you don't expect them to have like a meticulous understanding of financial processes and receipts and everything. So also there needs to be more and more understanding of like the realistic expectations from an organization. So that would make the response a little bit smooth and faster, especially in times in crisis. And the last point, apologies if I'm too long, is around the intentionality around bringing peace to the region. So no matter how much resources you invest in health system strengthening country X, without ultimately bringing peace to that region, you just put yourself on the risk of shooting yourself in the foot, putting more resources into a hospital that will eventually crumble just because you cannot sustain it. So I'll stop here in the interest of time, but thank you so much for the session.
No, thank you. That's really helpful. Again, coming from the front line, and your really view on focusing on the peace building bit as well is very important. If there's I don't see any other hand raised, but there has been a few comments on the chat, so I'll cover these, and then I think we just want to make sure that this is not the only chance for us to actually kind of start thinking about what can we do internally, because I think it may be a question that's never occurred to us because we're in such a fast-paced, very, conflicting parties every day, changing situations every day. So it's often very hard to actually sit down and reflect on how can I actually be a bit more intentional. And this question may be more relevant to a protracted crisis setting or a country where there is a pocket of fragility. But I think it's really, really important for the NGOs or the implementers or the frontline actors, service providers, to really think about how can we go that last mile and what do we need to actually advocate for any practical changes to the funders within the country coordination mechanisms or any kind of groups that you're part of to actually take it forward another step. So Louise has actually flagged a webinar that's hosted by her organization, the Global Health Partnership. I think she's left the meeting, unfortunately, but there's another series of another webinar exactly on this topic, which is very welcome news that this health system strengthening is in fragile contexts is being much more discussed within the fora. So please do join and contribute to it as well. Obviously, because of the nature of their organization, they do focus a lot more on the health workforce. So it may be another chance to actually really focus the discussion on health workforce side of things. And I think there was another comment and on from Ashish. Thank you, Ashish, from our own organization. I think could you speak on more of adaptation recommendation and if it addresses the need of health systems to ally. So I think Noemi, if you can maybe answer this question in the chat. Or I think what we will do is in the email we will be providing the context of each of the speakers. So if you have any remaining questions, please do reach out. And I think reaching out would be great because not only will it answer your question, but it might open up opportunities for collaboration. I've actually seen, two participants talking about the need for this in Yemen, and I think it's really about this networking that breaks down the silo that we are all talking about. So thank you very much for this. I think with that, I will hand over to Katie since we have 1 minute left.
Thank you so much, Jean. It's been amazing to see the level of enthusiasm, both in the participants and also in the very active chat all throughout this discussion. I wanted to start off with some thank yous. Thank you so much to our fantastic set of speakers. Thank you, Mustafa, Maria, Fatima, Noemi, Jean. Thank you so much for taking the time to share all of your amazing knowledge and evidence. It's been just fantastic to have a chance to delve into that. And yeah, I think the number of people in the room speaks in and of itself to the level of interest in this agenda and taking these discussions forward. Thank you so much to Bond colleagues for co-hosting this webinar with us. We felt it was really important to bring together both the Bond Humanitarian Group and Action for Global Health to really speak to that nexus across development and humanitarian. In terms of next steps, there were sort of two main things I wanted to flag. Firstly, this has obviously been recorded, as everyone's aware, so we will be sharing the recording and also all of the resources that have been shared in the slides, as well as the slide deck. I think that'll be coming around tomorrow to all attendees, so please do share with others who you think it might be relevant to send to. And the other thing I wanted to flag, sort of building on what Jim was saying about, hopefully this being the first of multiple conversations, just to say that Mustafa and myself are in particular following up with FCDO colleagues to see if we could facilitate a sort of follow-up roundtable discussion specifically with them as obviously a key donor in this space. So we're going to be scoping whether that might be possible in early 2026. So please look out for maybe some further communication and opportunities to keep the conversation going, in particular with UK government.
Otherwise, thank you so much, everyone, for taking the time. Thank you for staying on for the extra 12 minutes. Really, really helpful. And hope you all have a fantastic rest of the day. Yeah, final thanks again to all of our speakers. Really great to see you all. Thanks, everyone.